Hi, you're watching Nursinga, and today we're talking about cardiovascular and shock disorders of pediatric patients, and this is part of our summer paramedic lecture series. So let's start by talking about the structure of the cardiovascular system. You're familiar with the heart and the chambers. Well, let's talk about those blood vessels. So sometimes people get a little confused about the difference between an artery and a vein. So arteries carry blood away from the heart. The pulmonary artery carries the least oxygenated blood in the body, and the aorta carries the most oxygenated blood in the body. And so it's kind of a misnomer when people say arteries carry oxygenated blood. Most of the time that's true, but that's not really what they do. These are high pressure vessels on kind of the exit portion of the pump that carry blood to the capillaries so that it can perfuse cells. So when you think about the arteries, they're really responsible for specifically perfusion. And it's the artery that you compress against like a bone or a solid structure in order to feel a pulse. So normal perfused skin is pink or pink toned, like warm toned if it's darker pigmented, warm to the touch, pulses are present, there's brisk cap refill. Nutrients are also delivered as part of that perfusion. So it's not just oxygen, but also glucose and proteins and everything else. So without adequate perfusion, we wouldn't have good hair growth and healthy looking skin. You can see in the picture that arteries have this nice, thick, muscular layer. And so arteries are really good at constricting, and they can alter blood flow and kind of reroute things based on constriction. And then we have our capillary beds, and there's pre and post capillary sphincters, and those also help to kind of shunt blood or reroute blood. So when we talk about vasoconstricting and blood shunting, we're very specifically talking about the arterial and capillary side of things. Veins are capacitance vessels. So these are responsible for carrying blood back to the heart and the lungs. The lymphatic system runs parallel to the venous system, and a lot of that kind of interstitial fluid is picked back up and filtered by the lymphatic system before it is returned to the central circulation. So veins are responsible for the assistance in removing waste products and collecting fluids from the lymph system and tissues. At any given time, about 30% of your circulating blood volume is in the arterial side, and then about 65% is in the venous side, with about 5% in the capillaries or the other tissues. So when we think about blood distribution, and we think about manipulating blood vessels to raise or lower blood pressure, we're thinking about arterial constriction with alpha stimulation to raise blood pressure, and we're thinking about venous dilation with things like nitrates to decrease preload and blood pressure. So we can manipulate, with this knowledge of A&P, we can manipulate these vessels in order to help us achieve homeostasis. We need to understand normal values, and when we're talking about shock and cardiovascular disorders, one of the things that we're concerned about obviously is end organ perfusion, and that still requires a mean arterial pressure of roughly 65. So normal blood pressure is estimated by age. Now a newborn typically has blood pressure, like 60 in the 60s, but as we get closer to a year old, this is kind of the formula that we use. So the age in years times 2 plus 70 gives us the lowest systolic blood pressure that we would accept. And then we take that number and we add 20 to it, and that would give us our average systolic. And we subtract 20 from that original lowest number, and that would give us an average diastolic. So we say the age in years times 2 plus 70 and then plus or minus 20, and that's kind of the calculation that you can use. Again, using some sort of a chart or a written reference is much more accurate, and doesn't lead to that 2 a.m. miscalculation problem. By about 15 years of age, we have our 120/80 blood pressure. So even though we consider teenagers to still be children, physiologically by between 12 and 15, their vital signs and homeostasis needs roughly are equivalent of an adult. So I just mapped some of this out for you so you could kind of look to see what it looks like. But a 1-year-old would be then 1 year times 2 plus 70 would give us a minimum systolic blood pressure of 72 and an average blood pressure of 92/52. And then you can look at the rest of that chart. But by the time we're 9, our blood pressure is about 108/68, and our minimum systolic blood pressure should be about 88. And you'll notice if you wanted to map those out that the mean arterial pressure is greater than 65 in those. So the take home from all of this, though, is when you look at that equation, it starts at 70. So I want you to be aware of any systolic less than 70. That's considered hypotensive regardless of the age, except for that, freshly newly born child. All right, so let's start off talking about shock. And we're going to talk about some cardiovascular stuff and cardiogenic shock, but let's just talk about shock in general. Shock occurs when anything interrupts the supply of oxygen and nutrients to the cell. And we often oversimplify that by saying it's a problem with the pipes, the pumps, or the fluids, but really it is anything that causes cellular dysfunction, right? So whether it's hypoxia or lack of glucose or an accumulation of waste products or acid-base imbalances, any of those things, when I start to have cellular dysfunction, then I'll have tissue dysfunction. And when I have tissue dysfunction, that will create organ dysfunction. And then that will create organ system dysfunction, which then will create organism dysfunction, which is me. So I'd like to keep my organism working, and so that means then that I have to keep all of the cells in my body happy and well perfused. The types of shocks that pediatric patients experience are the same as adults. And we think about those as cardiogenic, which is typically left pump failure and decreased cardiac output. Distributive shocks like neurogenic, anaphylactic, or septic, where we have decreased preload from vasodilation and increased capillary permeability. Hypovolemic shock, which could be loss of fluid or blood, leading to decreased preload. And obstructive shock, and this is problems with filling or pumping due to an outside problem like a tension pneumothorax, a cardiac tamponade, or mediastinal tumors. So I'm not going to go in depth about obstructive shock. If the person has a tension pneumothorax, you're going to decompress them. We can't fix a cardiac tamponade in the field under normal circumstances unless you work someplace where they give you permission for pericardiocentesis. And obviously we're not going to do surgery to correct a mediastinal tumor. But if you do have a kiddo who has lymphoma and they have a known mediastinal tumor, some big tumor in their chest, that could obstruct either inflow, so preload and return, or outflow, and more likely in that case it would obstruct inflow. So again, things that we're thinking about with shock: is there enough oxygen getting to the cells? And that requires obviously blood vessels, and it requires intravascular volume, and it requires hemoglobin and red blood cells and the ability to transport oxygen, and it requires adequate acid base because I can't get temperature control, because without homeostasis, that oxygen doesn't release correctly, it doesn't dissociate correctly and get onto those cells. Do I have enough glucose in order for those cells to do work? Is my vascular volume adequate to actually make it to those cells? And thinking about that, not just that, but what if I have really significant, peripheral edema or something like that? If I have a lot of third spacing, so fluid in those interstitial spaces, I can't get fresh plasma and oxygen and nutrients to all of those cells, and so they'll start to have cellular dysfunction. And then do I have a functioning lymphatic system and kidney and liver system? Can I remove waste as I need to maintain homeostasis? So I like to think of shock as being a disruption of homeostasis at the most simple level, which is a cell. And when enough cells are experiencing a disruption of normal functioning, we start to have a systemic problem, and that is shock. So we talk about compensated and decompensated and irreversible shock. Other terms you might hear used are things like non-progressive and progressive shock. I just want to talk a little bit about what this looks like as far as the pathophysiology. So the physiologic responses in compensation for shock, and let's just say at this point we're talking about like dehydration and hypovolemic shock, because that's the most common type of shock we'll see in the pediatric patient. So we have baroreceptors, and those sense a drop in blood pressure. So baroreceptors sense pressure, and as our blood volume falls, our baroreceptors say, hey, our tank level is getting a little too low, so I don't have enough fluid, so it releases through sympathetic nervous system stimulation, epinephrine and norepinephrine from the adrenal glands, right? And then we have with our epi and norepi both alpha and beta stimulation. So I've got alpha 1, which vasoconstricts, and then beta 1, which works on heart rate, force, and automaticity, and beta 2, which is a bronchodilator as well as a pulmonary blood vessel dilator. So basically, my sympathetic nervous system is increasing my cardiac output and my oxygenation and my ability to get rid of CO2. At the same time, when I have decreased circulating blood flow, I'll have decreased oxygenation and perfusion to my kidneys. And when the kidneys sense low fluid levels, they release renin. Now, renin then activates the RAS system. So that's that renin, angiotensin, aldosterone system. Renin is released from the kidney into the bloodstream. The bloodstream always has angiotensinogen circulating in it, which is actually made by the liver. Renin activates angiotensinogen into angiotensin 1. Then it's still in the bloodstream. It gets circulated around to the lungs. In the lungs, ACE, or angiotensin converting enzyme, turns angiotensin 1 into angiotensin 2. So it converts 1 into 2. Angiotensin 2 is the active form of all of these hormones or enzymes. So angiotensin 2 then further stimulates the sympathetic nervous system. It releases aldosterone, and it causes vasoconstriction and sympathetic stimulation, as I said, with the epi and norepi. It also releases or triggers the release of antidiuretic hormone, which basically says, hold on to water. And aldosterone is the exact opposite of spironolactone, which is a diuretic. So aldosterone causes our kidneys to reabsorb sodium and water, but excrete potassium. So in response to a hypovolemic state, I have epinephrine, norepinephrine, antidiuretic hormone, aldosterone, and angiotensin 2, all working to hold on to whatever blood volume I have, decrease urinary output, increase cardiac output to maintain end organ perfusion. Obviously, the biggest end organ that we're worried about is our brain. So the goal of all of this is to maintain adequate oxygenation and circulation, so perfusion to the brain. So antidiuretic hormone is released when the posterior pituitary senses hypovolemia, and again tells the kidneys to resorb water and sodium. And then with all of this, we also have an intracellular fluid shift. So as I lose volume from my intravascular spaces, I'm going to start pulling from those interstitial spaces to maintain blood volume. And then that means that the cells lose fluid out of the intracellular space that kind of backfills those interstitial spaces. And that's important because this is the process that causes that tenting turgor, that poor skin turgor. Okay, so when we're thinking about hypovolemia, that intracellular fluid shift and that interstitial fluid shift back into the intravascular space is important because it develops physical findings that we're going to see on exam. As shock progresses and we have progressive shock or decompensated shock, we'll start to have altered capillary permeability. As we start to have cell membrane dysfunction and we start to have a problem regulating capillary constriction, we'll have fluid and proteins that leak into those interstitial spaces. Now that's a problem because proteins are a large molecule and water follows everything. Like think about water as a groupie. Sugar, it'll follow it. Salt, it'll follow it. Proteins, it'll follow it. Cells, it'll follow it. Basically, the take home is water has no mind of its own. So when we're talking about fluid shifts, it's following something, whether it's an electrolyte like sodium or potassium, or whether it's glucose or protein. So when we start to lose proteins into interstitial spaces, like someone who has cirrhosis of the liver, that's going to give us really severe ascites. The same is true here. When we start to have massive capillary leak, we're going to lose proteins and we're going to have massive fluid shifts. We have respiratory insufficiency that leads to pulmonary edema, again from those leaky capillaries, and impaired gas exchange. We have cardiac depression. So the heart needs glucose and oxygen and an appropriate acid-base balance in order for the myocardium to really function appropriately. It's also really sensitive to imbalances in sodium and potassium and calcium. So as we get sicker and sicker, we have problems then with normal myocardial contractility. So this decreases preload, stroke volume, cardiac output, blood pressure, and our mean arterial pressure decreases. So basically that's like a catch-22 because the sicker you are, the less well your heart works, and we need it to work better so that we can get better. So all this then causes tissue hypoperfusion. So we get organ ischemia, our kidneys, our intestines, our skin, all of that starts to shut down. And then when our tissues get ischemic, they start to release different enzymes into the bloodstream that can impact the heart even further. And then neurologically, we have decreased cerebral blood flow that leads to significant altered mental status. So let's talk about specific things for pediatrics. This is a picture of tenting skin turgor or poor skin turgor on a dehydrated infant. One thing that you do need to know is that you can't trust tenting turgor in a child who's malnourished because they will tent regardless of their fluid status. So hypovolemia is the most common cause of shock in infants and children. Their small blood volume relative to an adult makes them really sensitive to any increased losses or decreases in intake. So things like trauma, illness, vomiting, diarrhea, fever, all of those things can have a relatively rapid impact in their fluid balance and cause them to go into hypovolemic shock or at least be dehydrated. Early indications of hypovolemia include tachypnea and tachycardia, pale or mottled skin. Initially, the extremities are cool, and then later on, the whole body becomes cool. Our systolic blood pressure in kids drops faster than their diastolic, so they have a narrowing pulse pressure. They have evidence of changes in cardiac output, but you know, again, we're looking at that overall mean arterial pressure. It doesn't look so bad, and this is where we get into trouble because, you know, I'm sure you've heard it, but people say like kids compensate, and then die, and that's not true. Kids have signs and symptoms of early shock. We miss them. And so basically it's like, you know, paramedics miss it, and then the kid is dead. That's more accurate. Not just paramedics, all of us. So later manifestations of shock include altered mental status, slow, sluggish capillary refill, cold extremities, and cooling core, hypotension. Infants under the age of 1 may also have sunken fontanelles. Once the fontanelles close, obviously those aren't going to be an issue. And then dehydration specifically, so remember with hypovolemia, I can have a hemorrhagic cause or I can have a fluid loss cause. So thinking about dehydration, so the fluid loss cause specifically, that results in a lack of tears, sunken orbits, dry cracked mucous membranes, especially like the oral mucosa, and tenting and poor skin turgor. And you know, they say like the eyes are the window to the soul. Well, with kids, as soon as they get edema, they get swelling like around their eyes, and as soon as they get dehydrated, they get this sunken appearance around their eyes. So always look at the kid's face closely. And then the other thing we might notice is that the care provider may report a decrease in urination. So in addition to losses and poor intake, we may see a decrease in output as well. So how do we manage hypovolemia? So if we're just talking about dehydration, we want to get IV or IO access if the kid can't take adequate oral fluids. I'll tell you, pediatrics and adults, oral rehydration is always preferred because it's safer and it's more effective. But if that's not an option, then we're going to go for intravascular, intraosseous. Boluses are calculated at 20 milliliters per kilogram, and a bolus ideally, according to PALS, should be over 5 to 10 minutes. Like if the kid has any comorbidities like congenital cardiac defects, anything where you're worried like they won't be able to handle that volume, you can just do 10 milliliter per kilogram boluses over like 20 minutes. So you can kind of cut the volume down a little bit and give it a little bit more slowly with careful reassessment of the lung sounds for crackles and watching for distended neck veins and things that would tell us that the patient was in fluid volume overload. For kids, we always use isotonic fluids, so 0.9% sodium chloride, which is normal saline, is going to be preferred. We would never bolus like a D5W, like as a bolus fluid, right? We would never use like a D5W. So use warm fluids whenever possible because we know that there's a correlation between hypothermia, hypoglycemia, and acidosis, especially in kids, but also in adults. And antiemetics like ondansetron, which is Zofran, are safe for use in pediatrics. So follow your local protocols. But if the kid can't keep things down because they're vomiting, then we want to try to get something into them. For trauma, then obviously, this is not just straight out dehydration. We need to control the bleeding if possible. If it's an internal bleed, then obviously they need surgery, so we want to minimize scene time. Our protocols in Vermont allow us to use TXA on people older than the age of 15. And if you need it for somebody younger than that, that would be a medical control discussion. Moving from hypovolemia to distributive shock. In distributive shock, I have not lost the fluid outside of my body. I've simply changed where it is. So my distribution has changed, and therefore I have decreased my preload, which decreases my stroke volume, which decreases my cardiac output and my blood pressure. So the types of distributive shock are anaphylaxis, sepsis, and neurogenic shock. For all of these, we're going to obviously include IV fluids and then pressors if needed. For anaphylaxis, though, we're going to treat the anaphylactic shock with epinephrine, 0.01 milligrams per kilogram IM of the 1 milligram per milliliter concentration, and that has a max dose of 0.3 milligrams for a child. You want to use the vastus lateralis or rectus femoris, so the lateral thigh, kind of mid-anterior lateral thigh muscle for all of your rescue medications. We don't like to do deltoid shots until kids are at least 5 years old, and ideally the deltoid should be reserved for immunization. So I think of arms as being for vaccination, immunization, and legs as being life-saving. Bronchodilators is needed for bronchospasm, so if you have respiratory component and the patient is wheezing, you can use albuterol or a combination of albuterol and Atrovent. Diphenhydramine, which is Benadryl, you can give at 1 milligram per kilogram with a max of 50, and that really is for itching and histamine suppression. And then steroids also can be used for anaphylaxis. Dexamethasone is dosed at 0.6 milligrams per kilogram with a max dose of 10, and methylprednisolone solumedrol at 1 milligram per kilogram with a max dose of 125, which is the adult dose. With anaphylaxis, if it's a bee sting, look for the stinger, remove the offending agent if you have it. Sepsis, so we know what septic shock is. It's no different in children. The big take home is that pediatric patients need usually at least 3 boluses, but sometimes they need like 4 to 6 boluses to achieve normal perfusion. So depending on where you work, your protocols may tap out at like 3 boluses and then call medical control, but don't be afraid of that fluid. Remember, in a perfectly normal vascular environment, only 30 to 40% of IV fluid is still in the venous system after an hour. And when you have a distributive shock environment where I have dilation and capillary leak, that fluid is just going into those interstitial spaces. So you're going to need to keep going with those boluses to fill the tank. We can also use vasopressors like norepinephrine and epinephrine for their alpha effects to help decrease that capillary leak and to increase blood pressure. Norepinephrine is 0.1 to 2.0, so 0.1 to 2 micrograms per kilogram per minute, or you could do an epi drip at 0.1 to 1 mics per kg per minute. Heart failure is essentially anything that impairs the left ventricular volume ejection fraction. So anything that decreases cardiac output from the left ventricle is going to cause what we refer to as heart failure. And this could be a congenital defect. It could be, some sort of injury, myocarditis, which is usually caused by a viral infection, or cardiomyopathy, where we have either congenital or acquired heart muscle damage. And we can have dilated cardiomyopathy, where the heart is just basically this kind of big floppy holding organ and does a really poor job of squeezing. Or we can have hypertrophic cardiomyopathy, where we have hypertrophy of the ventricular wall, so the opening in the left ventricle is much smaller, which then leads to smaller volumes and smaller stroke volumes and cardiac output. Congenital heart disease is definitely a concern, and we have looked at like the more common congenital heart defects, but it's important to remember when you're doing your assessment, if you hear a murmur or any like gallop or abnormal heart sound, if the baby is tachypnic and having a hard time feeding, if they have failure to thrive or a low weight gain, so they're not getting weight and hitting their milestones normally, and excessive sweating, especially like forehead sweating, those are all signs of congenital heart disease. One of the things we have to remember is infants in particular have to be able to do this like suck, suck, swallow pattern when they eat. And if they're working really hard to breathe, like when they're tachypnic, they can't coordinate the suck, suck, swallow without choking and gagging, because they're trying to breathe while they're trying to suck and swallow. that's just a good indication that there's something wrong. And so sometimes the family will call you and they'll say like, well, my baby's fussier than normal. That's a big red flag for me, because a fussy baby that parents who have bonded with the child can't console, that's a red flag that there's something wrong. So the worst form of heart failure is cardiogenic shock. Again, it can be caused by things like congenital heart disease, myocarditis, cardiomyopathy, or even dysrhythmias that are interrupting normal cardiac output. And babies can have AFib. So an infant with AFib loses that atrial kick, which is the 20 to 30% of preload, and then they're going to have a decrease in cardiac output, and that can put them into failure. So presentation is just like heart failure. They're going to look like their fluid volume overload. They're going to have jugular vein distension, crackles in their lungs. They might have an enlarged liver, the hepatojugular reflex. So when you push on the liver, their JVD increases. They could have S3, so like a gallop or a murmur, shortness of breath, poor feeding, sweating, all of those things again. But specifically with cardiogenic shock, we're looking for hypotension and poor organ perfusion. So they'll also have that irritability, restlessness, anxiety. Management depends on the symptoms. So we always want to try to get like a really good physical exam and history, and then we want to plan our attack based on what we think the most likely underlying cause is. Oxygen is good for all of these babies, so we want to support them as much as we can. Position of comfort. Most babies or kids in cardiogenic shock are not going to be able to tolerate being flat, just like the adult in congestive heart failure will not tolerate being flat. So you're going to have to kind of gauge what to do. So you may need to elevate the shoulders and the head. And then destination determination and transport mode will be based on where you are and where the nearest PD ICU or PD cardiologist is. If you're very far and you can't get a helicopter, go to your nearest center for stabilization is always a good take home, or call medical control. So for management of pediatrics with cardiovascular complaints, again, we're going to utilize the pediatric assessment triangle to determine severity of the situation. So remember, that's appearance, which is the Tickles mnemonic. So the muscle tone, the interactiveness, consolability, their look or gaze, and speech and cry. And then we want to look at their overall work of breathing. So do they have increased work of breathing, normal work of breathing, decreased work of breathing, or are they not breathing? And then circulation to skin. And so for the skin, we're looking for any obvious rashes, changes in color, pallor, cyanosis, modeling. Sick kids with cardiovascular problems usually present with an altered appearance, effortless tachypnea with no increased work of breathing, and pallor or modeling. So I want you to make some sort of a flashcard or something for yourself that says effortless tachypnea is an indication of shock. So when we hyperventilate, or when we have tachypnea, we are doing that in order to blow off CO2. And so in pediatrics, when they have effortless tachypnea, this is a perfusion problem, and I now have an acid-base imbalance that I am attempting to compensate for. So remember that as hydrogen ions elevate in the body, CO2 also elevates in the body, and so I'm going to want to blow off more CO2 by breathing more quickly. So kind of rapid, deep respirations. Check carefully for signs of fluid volume deficit and fluid volume overload. Again, look at the orbits, look at the neck veins, look at the skin, think about the fontanelles if they're under a year, look at the mucous membranes, think about urine output as well. And then manage findings and complaints as you find them. Patients with distributive shock may appear to have flushed skin or hives at first, but then as shock progresses, the patient will become pale, cool, and clammy. And as I mentioned before, sweating of the forehead in children is a sign of a congenital defect, especially congenital heart defects. As a rule of thumb, I'm a creature of habit. I always utilize the vomit mnemonic. So if I'm, with a particularly sick or complex patient and I want to pause for a second and regroup, I'll think to myself, have I checked all of the vital signs, including temperature? And when was the last time I checked them? Do they need to be checked again? How am I doing with oxygen? Do I have evidence of adequate perfusion? Do I have normal mentation? I can have an O2 sat of 100%, but if I don't have oxygen that can get off of the cell at the brain, it's not doing me any good. So thinking about oxygen and airway stuff again. Monitors. So I have the patient hooked up to all of the monitors. The sicker the patient is, the more monitors they need. And don't be afraid to use end-tidal CO2 in pediatric patients as well. Do I need to check a glucose, right? So think about all those little toys and machines that I have at my disposal. IV access and fluids. So I want to go back again. I want to reassess after each bolus. How did I do? What's my blood pressure now? What's my fluid status now? Do I need another bolus? And then treatment and transport decision. So this is kind of the vomit mnemonic. Use it if you like it. Don't if you don't care for it. It's totally fine. But this always kind of just helps me organize my approach. And if I need to just take a second and regroup, this is where I go. Drug therapy. So we've talked about vasoconstrictors, or alpha adrenergic drugs. These are drugs like dopamine, epinephrine, norepinephrine, and phenylephrine. So these are alpha drugs that cause, again, arterial constriction and capillary constriction. So these will help us shunt blood back to the core and move more of the circulating volume into that venous side in order to have adequate preload. Agents that enhance contractility are drugs that you might see on a transfer. So these would be like digoxin, which is a cardiac aminoglycoside. It increases the force of contraction without increasing the heart rate. We have dobutamine, which is an alpha with some beta, but it increases contractility of the heart, so strength of contraction with minimal effects on heart rate. And then we have milrinone, and milrinone is also used to enhance force of contraction. This drug oftentimes is put on a pump, very similar to like an insulin pump. It's a milrinone pump, and the person has to wear it 24/7. If you are on like a heart transplant list, so if you have like complete kind of heart failure, your pump has failed completely, not just congestive heart failure, but you need a heart transplant. Milrinone is kind of a stopgap measure. I have taken care of a couple patients who were end of life on milrinone because they weren't good candidates for heart transplants. They weren't good candidates for VAD, or ventricular assist device. And so they ended up on a milrinone drip instead. So things that we need to know about that, if that runs out, or if for some reason the pump malfunctions and they're not getting the med anymore, they're going to die pretty rapidly. So be aware of milrinone. There are pediatric patients that are on it for cardiogenic shock issues. And then agents that enhance myocardial perfusion, so dilating the coronary arteries, calcium channel blockers, nitroglycerin, sodium nitroprusside. So I didn't put the calcium channel blockers on here, but use the nitroglycerin and the nitroprusside, dilate the coronary arteries and enhance myocardial perfusion. So it's important to think about, like, when we're giving a drug, why we're giving the drug, what the expected therapeutic outcome of that drug would be, and then, obviously if there's any side effects that we should be monitoring for that would cause us to want to stop the drug. So management overall for pediatric patients with shock. So again, this is usually trauma, dehydration, fluid loss that is the primary cause of shock. So we're going to watch for any worsening of their condition: restlessness, that effortless tachypnea, tachycardia, pallor, thirst, decreased urinary output, narrowing pulse pressure, and hypotension. Treatment includes, again, ventilatory support, so airway, breathing, oxygenation, cardiovascular support, so fluid boluses of 20 milliliters per kilogram of normal saline, and then vasopressors like an epidrip, push dose pressors, norepinephrine. We want to correct any underlying acidosis, hypoxemia, hypoxia. And so the difference, remember, is hypoxemia is a low O2 sat in your blood. Hypoxia is a lack of adequate cellular perfusion. So really, hypoxia is the one we need to correct. And then hypercarbia, which is too much CO2. Hypothermia, hypoglycemia, and electrolyte imbalances also need to be corrected as much as we can in the field in terms of, you know, what we can find and what we can treat. So to recap, in shock states, there's a problem with cellular perfusion, which leads to decreased cardiac output or a decrease in peripheral vascular resistance, so that you know, dilation of the arteries and the capillary beds and that capillary leak. It can be also related to you know, problems with the heart pumping, problems with the blood vessels themselves, and problems with blood or plasma levels, inadequate oxygenation, and all of these then lead to that target organ dysfunction where the brain no longer can work and control the body the way that it should. So treatment of a patient in a shock state, especially pediatric patients in a shock state, is focused on restoring perfusion, specifically to the brain, but obviously ideally to the whole body and every single little cell in the body. So think about the underlying cause, fix the problem as much as you can, monitor that patient really carefully. Again, you can use my vomit mnemonic if you want. Oxygen, IV fluids, and then vasopressors to maintain an adequate mean arterial pressure and cardiac output. As always, thanks for watching, and I'll see you at the next one.